I also have the distinct honor of introducing our opening keynote speaker, who is Dr. Julia Adler Milstein, and she is a professor of medicine and chief of the Division of Clinical Informatics and Digital Transformation at UCSF. She holds a PhD in health policy from Harvard. And when she joined UCSF in 2017, she was the inaugural director of the Center for Clinical Informatics and Improvement Research. And then she became the inaugural chief of the Division of Clinical Informatics and Digital Transformation in 2023. She has had an outsized impact on our field, having published more than 300 papers. She's testified at the U.S. Senate, as well as the Education, Labor, and Pensions Committee. She is a member of the National Academy of Medicine, and she has been named one of the top 10 influential women in health IT. And of course, that's just the tip of the iceberg when it comes to her many accolades and awards. So we feel very lucky and blessed to have her here, and I'll have her take the mic.
Thank you. All right, I think they're having me use
awesome.
this one. Thank you so much. That was such a lovely introduction. Hello, everyone. I'm really thrilled to be here today. I love this meeting. I think I've come, maybe not all 7, but many of them, and it's just such a great opportunity to bring a group together and have really a conversation about this ever-changing field. Roxanne, as you were saying this morning, have you been wowed by AI? Literally on my drive this morning, I pulled up an email from a startup company that I'm working with that takes a bunch of regular images of you, like one of those that you just saw, and puts it together into an AI-generated one. I looked really good. It's the fun thing. I'm not going back to regular photographs ever again. It is wild to see. So, I mean, the field really does change so quickly, and just the new applications of AI are stunning and breathtaking. So. I'm really excited to be giving you this talk today. It's a brand new one, and one that I hope will be a conversation that we can have, so there will be some interactive components to it as well, and anxious for your feedback on it. It's sort of crystallizing for me. I did have this, academic career, writing lots of papers, but really in the last year and a half, as I've launched this new division, it's been an opportunity to get a lot closer to our health system and to think about, as they are trying to make decisions about this explosion of AI and how do we implement it safely, how do we ensure it's effective. We're really bringing to bear some of our research expertise in a real-world clinical setting. And what I want to describe to you today is what I'm seeing as this emerging science. I think Nigam and others have described it as, health delivery science around AI. And so today is my opportunity to really articulate what are the North Star questions of this emerging delivery science. But before I get into that, I thought I would start with a bit of a personal story. When I come to Stanford campus in June, I always think back to this day. Does anyone know who this is? So this is Carly Fiorina, who was the commencement speaker for the Stanford class of 2001. I actually went back and looked at her talk, and she gave a very sort of classic talk, take risks, be bold, all of that. But maybe I was the only person who took away from that commencement speech a real love of enterprise technology. I was like, this seems really interesting. And how do you get really large organizations to adopt technology? So I actually took away from my commencement speech on this campus a few years ago this really deep interest in enterprise technology. Pulled that thread and was really fortunate to take courses from these 2 people. Anyone know either of these people? Yeah, Eric. Okay, one of them should look familiar because you successfully recruited him to Stanford from MIT. The other is Wanda Orlikowski. 2, I think, just incredible researchers, one who focuses more on the socio-technical aspects of IT adoption, and one who focuses more on the economics of IT adoption. And I thought, gosh, these are both such interesting fields to think about. How do we get the economics of IT right? How do we get the socio-technical features of AI right so that it's actually used in complex systems? So again, pulled on those threads a bit more and found my true passion, which is thinking about these issues in the healthcare context. And over the course of my career, have had these sort of 4 eras of research as enterprise technology has diffused and evolved into the healthcare system. The research follows it. And so I started my career thinking about electronic health records and interoperability, and then shifted to thinking much more about telemedicine as that exploded as an enterprise technology. And then over the past year and a half, it has been all AI all the time. And what's been interesting about these eras is that the drivers of them have been quite different. So the EHR interoperability era was very, very driven by federal policy. And so many of the questions that we asked in that era was like, did we get the policies right? And how did they make progress? What were the unintended consequences? And then telemedicine was obviously coming out of the pandemic era. And all of a sudden, we had a technology that I think had actually been ready to be used at scale for quite a long time. And we just needed the necessity of the moment where we had to push to all of a sudden implement it very quickly. And lots of interesting research questions coming out of that now that we're figuring out how to optimize it. Is it a complement? Is it a substitute? So I think we'll be studying that for years to come. But the sort of impetus of that era was, again, this global pandemic. And AI has been yet a new story, right? We don't have a huge policy infrastructure. In fact, states might be told any day now that they can't regulate anything around AI for 10 years. So I feel like the policy framework has been quite different than the EHR interoperability discussion, not as much policy. We don't have sort of a pandemic-like crisis that's pushing AI. And so what we really have here is just like a fundamentally new set of technical capabilities that feel like could solve really sticky problems in healthcare in new and exciting ways. And so I think all organizations are trying to think through, like, how do we do this work, given that it's not coming from a policy, given that we don't have a super crisis of urgency, how do we work with these technologies safely, and the fact that they're moving so quickly. So for me, that's what sort of made all of these topics interesting in their own and different way, and why I'm so excited to be working in this AI era, again, thinking about how do we study these tools as they're permeating into real-world clinical settings, both the sort of economics piece, the socio-technical piece. And so that's the conversation that we will have today. I'm going to start by stealing some slides from Amir Dan Rubin, who, again, should be a familiar name to this audience, former CEO of Stanford Health. He gave an excellent keynote address at the AIMI Clinical Informatics Conference last week. And I was really struck by this slide, where he talked about that one of the early hallmarks of the AI era is just how fast technology is moving, and that it's really moving faster than the people and processes can keep up. And I think, again, anyone who's working with these and making decisions about their readiness feels this very acutely. And I thought what was really interesting about this slide was that he pointed to sort of these like natural features that are sort of road bumps in the process, and that you have to work through to get from from invention to innovation. Again, that's not the one I think about as much, but this innovation to diffusion that I think about a lot, right? So things like learning curves, safety, organizational changes, laws and norms, like these are the speed bumps that we have. And again, they're very broad, right? They are people, they're process, they are regulatory as well. And so it's really thinking about how do we understand how to take those features and because sometimes the road bumps can feel frustrating and feel like, well, why are these in our way? But to use them in a productive way. And so again, this innovation diffusion piece and like thinking about those roadblocks for me was one aha moment. And then the second was this slide that he showed, which has these two dimensions of along which AI tools are arrayed, and it's market readiness and technical readiness. I actually don't agree with where a lot of the things are on this slide, which is not the point. But I think technical readiness, we all understand to some degree. But what is this market readiness, right? That was, again, as I looked at this slide, I was like, how do we characterize what market readiness is? And again, it's this people, process, incentive stuff. And so we point to it a lot in these like gross ways, right? Where we just say like, we got to get the people in the process right. But like, I want to answer, what does that mean? Like, how do we actually do that work? And like, what is the science behind that work? And so as I alluded to, I think there are other people who have been thinking about this. This is the paper that Nigam and Ron and other colleagues wrote, right? Developing a delivery science for artificial intelligence in healthcare. Right? This isn't work that we just point to as like all that other messy stuff you have to figure out. We have to figure out what the science is here. What are the scientific questions that we have to answer so that we can take this explosion of technical readiness, get it through those speed bumps of organizational readiness, safety, all that, and then achieve that dimension of market readiness. And so from this paper, they have, I think, a really excellent framework, and all of these will sort of talk about starting with the problem. Again, I think that is like now not a new idea, right? That the goal is not just to implement the latest and greatest technology, but to understand what problems we're going to solve and what AI solutions are best suited to address those problems. And so this is, again, I think, a really nice framework for thinking about how to break down the problem, designing the intervention, implementation, evaluation. They are AI-enabled interventions, but the broader context and framework around them is not just about the individual AI tool. So again, my goal today is to try to say, what is this health AI delivery science? How do we actually articulate what the most important questions are in this scientific framework? And so this is my own 2x2, because now we're starting to have these conversations regularly, and I see that there is a set of issues that are commonly discussed that I think are super high priority. So things for like need for AI governance and new leadership roles, right? So you see emerging in different health systems, like these chief health AI officer roles, right? So we are starting to get the people piece in place. Issues like addressing AI bias and drift once the models get into real world settings, they're being run on data that they weren't trained on. Again, like talked about these issues a lot. I think they are on the radar. Addressing the AI digital divide, another one that we're spending a lot of time talking about. So I'm not going to talk about those today. I think we've talked about them, they're on the radar. But what I want to think about is what is in this other quadrant of questions that maybe aren't getting as much attention, but are as critical to closing that innovation diffusion gap. So I'm going to propose 5 questions, talk a bit about them, but again, it's going to be more questions than answers at this point. And so we'll really be curious for your thoughts on, have I gotten the right 5 questions? Do you feel like those are really the critical ones to answer if we are going to have AI routinely integrated into care delivery settings? Okay, so the first question. Will EHI plus LLMs usher in the long-awaited patient engagement era, and are we ready if they do? So EHI is shorthand for electronic health information. For, I think, now almost a decade, we have had a policy framework where patients can download literally every piece of electronic data created by them in a healthcare delivery setting. And nobody really has done much with that data because they are messy and complicated and very, very hard to understand, even by an expert. And so what we are starting to see is now that there are large language models, highly engaged patients are taking a copy of their record, and in some cases even a much sort of broader set of clinical information, and starting to feed it into LLMs to ask questions that they think the healthcare delivery system has not adequately answered for them. And so, again, what we have seen is that we have made EHI available for a long time. I did a study with Chris Longhurst, another Stanford person. You've got so many great people here. And when Apple Health Kit was introduced, and all of a sudden, again, you could get data, your health record, download to your phone, and start to connect it to other Apple Health Kit features. And we took, I think, the first 12 health systems that enabled this for their patients and said, oh my gosh, it's can't wait to see all the patients who are using this. Basically, you could see it was less than 1% of the patients that were on the portal that did this, right? They did not come. And so that was sort of the first signal that it wasn't just about giving patients their data. We actually had to make their data easy to use in a way that we haven't to date. But where I saw the potential for this for the first time was a set of patients who we invited to speak in our seminar series that's called At the Intersection of Innovation of AI and Diagnosis. This is run through our Codex Center, a coordinating center for diagnostic excellence, and heard patients tell the story of what they've been able to do with their records plus a large language model. In this one story in particular, again, I know this patient has been very vocal about her experience trying to diagnose her son's what ended up being a tethered cord diagnosis over the course of 4 years, 80 doctor's visits, just an excruciating amount of pain that her child had to go through. And I think what I was really listening for is what did she actually have to do to get to that diagnosis? And what she had to do was to download not just sort of her summary record, but the radiology reports, and then put those radiology reports into ChatGPT and ask them to interpret them for her. And then she didn't even quite get there yet. She then had to ask them to basically reverse interpret them, put them back into medical language. And it was only after that process that she was able to arrive at this diagnosis that ended up being the correct diagnosis for her son. And so where I think we are headed with this is that we have the potential for EHIs plus LLM to usher in this new era, but we're going to really have to help patients understand how to use these capabilities. And I don't know if this story is going to be the norm or is going to be really the exception. And instead, we might have lots of patients who come in with lots of different ideas about their diagnosis and what's happening. And again, right now, I don't think we are ready for that. We don't have the capabilities yet to think through how to support our patients through that exercise. Should we be developing prompt engineering frameworks for them? What might that look like? How would we access that? Is this something we build into the patient portal, right? Lots of questions about how to support that. And then once patients do that work, how do we have those conversations with them? How do we follow up on what they think that they have discovered? So again, I don't know the answer to this question, but I think we can start to see that this is coming, and this is going to be a big piece of, again, how we leverage AI to be able to transform how care is delivered, and in this case in particular, how patients are engaged. I'm just curious, has anyone fed their own health record into an LLM? Okay, so maybe 10%. So I suspect this time next year, that will be higher. And again, I think it's, there's so many questions that we have about what patients will learn as they do that. But we've been talking about this patient engagement era for a long time, and I really do think that it's going to be here. Okay, so that's my first question, is the patient engagement piece. And I did start with that very intentionally because I think that's where we need to, in some ways, do the most work in terms of thinking about these capabilities and how to use them effectively, is to bring more stakeholders to the table, and especially patients. But the second question is more sort of health system centric. And again, is an idea that I have heard sort of circulated. Nigam Vinny Liu at Kaiser talks a lot about this idea. But how do we, at the very early stages, when we see an AI tool that exists or that might even be considered in development, how do we understand if there's health system capacity to act on the prediction of that tool or the output of that tool? So in my patient example, how do we know actually whether there is health system capacity if a patient brings a diagnosis from an LLM to quickly act on that? If we don't have the capacity to act on it, I do think we have to ask ourselves, have we added any value through this AI tool? Because it means you can't take the next step, and the next step is where the action and the benefit come. So we need, again, a systematic way, not each tool by each tool, but to, across a set of tools, say, do we have health system capacity to act on this? And then I think the second complementary piece is thinking about, do those leading the implementation of that particular AI tool or set of tools, do they have the authority to modify the system in the way that's needed in order to get that benefit? So for example, we looked at a tool at UCSF where there was detection of lung nodules as incidental findings. And then we had to ask ourselves, well, who will follow up on those once we find them? And we realized we actually didn't have the capacity today to do that. And so we're not going to move that tool forward right now because we don't have the capacity to act on it. And again, how can we do that work even more upstream so that we're only considering the tools where we do have the capacity to act, or we have the ability to create that capacity quickly? Because if not, again, we don't have a way to move that forward. So again, formatting got a little ugly, but we see, again, more and more of these examples of tools that have gotten pretty far down the implementation pipeline before we've gotten to that realization of, oh wait, we don't have the capacity to act on this. And so we want to move that upstream. So again, I gave you our example of lung nodule detection. Vinny Liu talks about how they encountered this problem when they did suicide risk prediction, right? So even a higher stakes use case, right? If you're going to detect people who are at suicide risk, you definitely need to be able to intervene on those quickly. And then another colleague who works at UCSF in our safety net setting, who has this really cool tool that does basically identification of abnormal mammograms so that you can do same-day follow-up. So when you come in for your mammogram, it's read right away, and if you need that follow-up, we can do it while that patient is there. But again, we need the capacity for that same-day intervention. So again, this is a quote from the paper that talks about some of these. And again, this idea that end users, including clinicians and health system leaders, may be particularly sensitive to the limited capacity of existing teams and providers to respond to a new alerting system. So again, we're seeing this problem emerge in many different small ways. So how do we start to address it at scale? part of the reason I'm confident that this is going to emerge into that top right quadrant on my 2x2 is that we are seeing that it exists in different frameworks, sort of the recognition of assessing this capacity upstream. Again, Nigam and colleagues have this firm assessment. And in this initial interview, right, sort of given the costs of the action, its benefit, and work capacity. So that's the point that I'm highlighting here, is like the work capacity piece. How do we understand work capacity and then match it to the selection of AI tools at a very upstream place? So that's the science that I hope we will work on to address this second question. Okay, so I'm going to move on to question 3. Which is thinking about what is the optimal unit of AI. What is the optimal unit to which you apply AI? That's the first piece. But I think the harder piece is then how do the units interact? And are we really heading towards what I think of as system-level AI that understands how all the parts of a given health system like UCSF or Stanford Health interact, the inputs, the outputs, the capacity, and can really start to direct humans and resources at that system level. So let me break that down again into a couple different pieces. So what we've seen an explosion of right now is what I think of as AI tools that do isolated clinical predictions, right? I just gave you an example, right? Suicide risk, lung nodule detection, right? They are detecting a piece of information for an individual that is going to be in sort of one part of a broader care pathway. And those tools are super valuable. A lot of times they bring information, insights that we didn't have the ability to identify before. But what we often don't think about is sort of how does that one piece of information change the whole process of what sits before it and after it? That's some of the capacity question that I just talked about and authority. But also just how does it change the whole decision-making trajectory? And what are the other pieces of information that piece of information needs to be put together with? And then what happens when each of those pieces has its own AI tool that's part of it, right? So right now, I think we haven't had to face this question in a lot of detail, because if you take any given sort of care process, care pathway, probably one, maybe two pieces of that pathway may have a piece of AI. But you could imagine a year from now, maybe the majority of that pathway will have an AI tool that's directed at part of it. And so how do we start to understand how all of those will string together, particularly as data from an upstream decision is needed to feed a downstream decision? And again, I think this is like, we're just trying to get our hands around individual clinical prediction tools. So the idea that we're going to need to think about them and understand them in like chains of clinical decision making feels a little bit mind-blowing right now. But I think we're going to have to figure out how to do that quickly. But that's not it, because what's going to be layered on top of those are AI tools that really tackle clinical or administrative tasks or processes, higher level tasks that are more generalizable. So these are things like AI tools that help with call center routing, or general purpose tools like our AI scribe tool that's being used across, right, all different types of specialties. It's not about supporting a particular clinical decision, but it's about capturing clinical documentation in an efficient way. Right? You can think about all the tools that fall into this category. And again, how will these tools interact with each other? And how will these tools interact with all of those individual tools that are making point predictions about something? That's sort of the third piece, that second piece. And then the third piece is, again, I think soon we will see AI tools that are taking it even up one more unit and thinking about the health system as a whole. And perhaps starting to predict how should we staff our ED today? Or how should we allocate a set number of appointments in this given clinical area? And so again, as you think about just the complexity of what goes on within a health system, how far away are we from a notion of a closed loop autonomous AI system that is like managing individual and population care, where the AI is starting to direct the people and resources that sit within a health system, right? We have nothing like that right now that we are thinking about, but I think it won't be long, in part because of the complexity of managing all those pieces that I just built up for you, right? So you can imagine it's just not going to be something that like a single human or group will be able to understand and manage all of these interdependencies, especially AI-enabled interdependencies. And so then we're going to need something that can understand the system as a whole, right? All sorts of like, you know, I can sense like a little discomfort when I started to get to this level, and it does feel uncomfortable, right? Because there is going to be values and ethics and things that you're going to have to program in to this system level AI, right? You're going to say things like, should we prioritize care for this type of patient or that type of patient? Is our goal to make $5 million next year or $10 million next year, right? These are the kinds of decisions that will have to be made to be able to have a system that exists at this level of scale. So again, exciting, little scary, but I think we have to be thinking about these questions of AI units, how they all come together, and then where this will all head as the complexity multiplies. Okay, I felt like today I was trying not to get too many issues on the table, but I couldn't just help but add this little addendum to this, which is that we also have to just think about sort of the EHR developer market here and the market power that comes with tools that will be more seamlessly integrated into your native EHR. Because again, of the complexity of adding all these AI tools, there is an incumbent advantage, and they are using that advantage in pricing models that are trying to make it very hard for health systems to work with third-party companies. I know there are other third-party companies that are trying to work against that. I had a conversation with Doug Fridsma on the way in about this very issue. And so we're not going to get into all the market dynamics today too, but it's something that's very much on my radar as we're really understanding how innovative we can be about how we approach this. So again, just sort of small addendum there. Okay. So question 4, this is something that again, I think many of leading health systems are thinking about, is how to bring AI into the health system in a trustworthy, responsible way. But because we're at the start of this journey, so much of the work has been upstream, the initial vetting of the tool and doing the work around what problem does it solve, who's going to pay for it. And what we haven't had as much time to think about is like the very last box on this screen, the monitoring and maintenance. And really, if you think about the trajectory of AI, we're going to spend 99% of our time eventually in the monitoring and maintenance phase. And so as hard as it is to sort of start to divert attention away from the initial vetting of this stream of models that are coming our way, I think we really have to be disciplined and to start to think about the monitoring. And I had a conversation with our radiology colleagues at UCSF recently because they actually set up their AI governance ahead of the broader enterprise governance because they've had to be thinking about how to bring AI tools in earlier than the rest of us. And I said, and so like, what are you doing for monitoring? And the answer was, oh God, like, don't ask me that question. Like, it's just so hard, right? Once the tool is in place to think about the monitoring piece. And so we've been really fortunate at UCSF to be able to launch a whole initiative focused on AI monitoring. It's been a really fun opportunity for my division to partner with our health system colleagues to think about what does robust AI monitoring look like. But it turns out that it's a lot of work to do AI monitoring well. And as we pieced apart the problem of like, what does it take to do robust AI monitoring, this is at least the initial set of capabilities that we identified. So one piece of it is the real-time monitoring, right? Like, so we need to be able to monitor the tools as they are performing in that very moment. So that means coming up with the measures that we want to monitor, visualizing the analytics, having drill downs because it may be in like particular service areas or particular specialties that we need to do that work. And then this is the piece I'm going to come back to in a minute, but like how to send real-time alerts to someone if we think that a model is not doing what it's supposed to do. And then there's the whole data integration layer, again, a whole infrastructure piece that sits around AI monitoring. We're thinking a lot about like AI, building an AI model repository, as well as something that captures our governance and compliance. So how can we store AI model history and how will we know when new versions are coming out so that, again, we can do adapt our monitoring as needed around those new versions. A whole reporting and analytics because different stakeholders want to know different information about these tools that may or may not be on our monitoring dashboard, and then like a whole coordination layer between all the different stakeholders. So we're at the start of this process, but again, I think this is so critical as a health system investment and to think about how to do this in a scalable way. So just to show you, as we've gotten into this work with our first few AI tools that we have deployed at enterprise scale, so we started with AI scribes because it was the most mature and widely adopted. And we said, okay, how do we do robust monitoring around AI scribes? So what we first did is we just started with a literature review, like what is known out there in terms of the measures that seem relevant for monitoring in general. Developed a framework that sort of combines the HHS trustworthiness principles with some that we thought were actually missing from the HHS framework things like measuring utilization, workflow impact, automation bias, healthcare professional experience, and patient experience. So that got us to sort of our full set of domains that we think should be monitored for any AI tool. And then we started to craft the specific measures in each of these domains for our AI Scribe tool, and then got a Delphi consensus group together. And what we realized is that as we started to build out the measures that came out of that consensus process, some of them were ready and like easy to build, but some of them actually needed some R&D work. Just as a very concrete example, one of the questions was like, what is the productivity impact? Like, how do we think about and measure the productivity impact of AI Scribe, going beyond just time-based measures, but things like RVUs and number of encounters? And so that we didn't have like a good off-the-shelf measure to do that in this context. So we sort of threw that over the wall to our R&D team, and then once that measure is ready, it'll come back into the monitoring process and be added to the dashboard. So again, this is why I believe that this work is the ideal opportunity for sort of those of us who have lived in a more academic space to come together with those who are really thinking about AI monitoring from a health system operations perspective and combine our combined strengths. And then ultimately, we put those measures into a dashboard. And so really just a few months ago, we have like our first AI monitoring dashboard that's up. And has, again, a lot of ways that you can filter and break down. This is actually only a subset of the measures, but we wanted something that was going to be understandable to the broad set of stakeholders that are interested in this, some of whom care a lot about the AI performance itself, some of whom really only care about like the money side of things, right? So our faculty practice office that put up the money for AI Scribes is like, well, how many people are using it? And are they happy with it, right? They're asking a very different set of questions. So we're trying to build a dashboard that will give everyone what they want in terms of the metrics and understanding the patterns. But again, to tell you, like the amount of measure development work that sat underneath this dashboard was massive, and it just feels unscalable if you told me we had to do this for 10 more tools. So again, this is where the delivery science piece comes in. Like we have to figure out how to do this in a scalable way. And my hope is that many of the measures will apply for the next 10 tools that we need to monitor, but like I don't know yet. And so that's what we're thinking about, is really understanding the scalability piece of this. But I do want to come back to this last piece because this has been really hard, is thinking about like when one of those measures on the dashboard changes, how much of a change means something is bad. Right? So if we saw a like 10% decrease in latency, for example, like that would be a good thing. Do we do anything about that? Or we just say like something happened that means that like this tool is performing better? But like what about a 10% increase? Like do we call the vendor? Do we alert the vendor? Do we do something about it ourselves? Like every measure we're trying to figure out like what is a threshold that means something, and then what do we do about it? And again, that's like latency is like a, well, no, I mean, I think it does actually have important implications for patient safety, but like some of these other ones, like what if all of a sudden in a model we see that it performs much worse for a certain subclass of patients, right? If we detect that change, again, what change is meaningful? What do we do about it? Who are the stakeholders that should be responsible? Do we need to staff them 24/7? There are like a million questions that we are asking about how to do this monitoring well. But at the end of the day, what keeps me up about this is like, if this did get to the issue of a patient safety incident, like this would come back to our team that's thinking about monitoring, and we will be asked, like, why did you not catch this? And so that's, for me, what is really lighting a fire under this work, is that we are putting these tools into real-world clinical practice, and they do have implications for patient safety and errors, and I want to know that we have built as robust an infrastructure as we can to catch anything that would go wrong. So as much as I think this is like a huge amount of complex work, like if we have to keep that as the North Star, because yes, we will figure out productivity and all those other things, the dollars matter, but that is really, for me at least, what drives the need to invest in this work and to do it in a robust and scientific way. Okay, we are almost at the end, but I have one more meaty question for you, so I hope you have a little bit more capacity to think about one last piece of questions that should be driving this health AI delivery science. And it's, what are the optimal investments to create an AI-ready workforce? So as I started my talk in saying I think that we have to have people and processes that keep up, I've talked a lot about processes, but I haven't talked as much about the people. And how do we think about what investments we need in our workforce in general, or in specific subsets of our workforce, to be ready to do work in a way that's going to involve AI to a much more extensive degree. So I think what we're seeing right now in the workforce world is like lots of programs like these. And again, within our Codex Center and the Gordon and Betty Moore Foundation that funded some of this work, right, you can now go out and find lots of training programs. And what I'm excited about is you're finding them in lots of places. So this is an example of something that was developed by the American Board of Family Medicine and is now like a training that they give at their annual meeting to help their workforce within family medicine feel like they are upskilled and ready to understand what AI is, how it will be integrated into their clinical practice. Over here is something developed by Cornelius James at University of Michigan. Again, these are freely available courses. This one's focused a little bit more on sort of how AI impacts clinical decision making. But like, you know, there's like 200 more, right, courses you could go out and find. So I think from a workforce readiness perspective, like we're pretty well down the road of thinking about like general purpose training. And if your research interest is in evaluating training and whether it's effective, I think you have lots of studies you can do because there's lots of programs out there to study. I will say in general, I think like training has not been so successful in like, for example, in the EHR era. So I hope that training as an intervention for workforce readiness is a little bit more effective in this context, but it's an empirical question. But what we're thinking a lot more about is when do we feel confident that our frontline clinician workforce are like ready to use AI tools and what types of stopgaps we should have in that process. And the hardest question has been, should we give these tools to our trainees? Because I think we feel pretty comfortable at giving them to sort of our attending physicians. So, you know, for example, AI Scribe or, you know, some of these other tools. But when we got to the question about trainees, it felt a lot more complicated. And we've been thinking about like, well, who do we talk to? Like there must be other organizations that are thinking about this. So just last week, I saw this headline where MGB is taking their ambient documentation efforts next. And the small line in the Becker's study, it said they're now piloting the tool's use among residents and fellows in collaborations with the GME office. So I emailed our GME office who had asked me, did I think this was a good idea? And said, I don't want to answer that question, but at least go talk to these other people who seem to be thinking about it too. And so again, I think this is going to be like a really, really tricky question because the benefits of the tools, for those of you who have looked at the literature, like it clearly reduces cognitive load, some, you know, smaller time savings, but like the clinicians really love it. And we know that, you know, our residents and fellows, right, really need those types of benefits. But at the same time, there's this real fear of de-skilling or maybe even never skilling. And so it's this sort of cycle of like, on the one hand, we want to upskill them to do the most important part of their jobs. But on the other hand, we're worried that these tools might take away really important skills. And so it feels like we're a little bit trapped in this cycle in these workforce discussions. Again, I think especially on the trainees, in part because we don't have a definition of what it means to be skilled. And so it's hard to measure de-skilling or upskilling if we don't have a really clear definition of skilled. And like, yes, we obviously have like medical competency exams, but I mean like skilled in like real world clinical practice settings. So in some ways what these conversations have done have forced us to go back to our whole approach to GME and trainee assessment and feedback, because we feel like we need to have those really buttoned up in order to then decide whether we're ready to give our trainees AI tools. Because if we don't feel like we've given them the robust training and feedback on the competencies, we're going to feel much less confident giving them tools that at least have a risk of de-skilling them. So again, a super interesting set of conversations. This is just one example of how the workforce conversations are playing out, but we're going to have to think about these again at a level of scale. And I think we're really at the phone a friend stage of this discussion. And so we'll need to think about, again, with our monitoring work, like how do we monitor for some of the things that we're worried about as we start to roll these tools out to our trainees. And again, it's going to come back to this question of how do we measure skill? And that's a big, hard question to answer. Okay, so you've made it through my list of 5 questions. As is clear, I think there are far more questions than answers at this point in the development of health AI delivery science. I think answering these 5 questions in particular is critically important, but super fun. It is, I hope it's been obvious from my just talking through them. There's just like, it's just a gold mine of interesting questions to ask. And I think those of us who have been studying clinical outcomes and clinical processes, like this is our moment to bring those skills to bear as AI tools hit real world clinical settings. So I think I will leave it at that. I think we have maybe some time for Q&A. Again, really curious on your list, what would have been your 6th question to add? Because what I really hope is that all of us will be developing this delivery science together, because it's the key work that's needed for AI impact to be maximized. So thank you so much for inviting me.
Question for you is, in healthcare, do we have any other examples that we can like look at? I know in the real world, like there's things like social media that moved faster than people in product, but in healthcare, do we have any other like examples that we could rely on about how things can go wrong or how things went right?
Yeah, it's a great question. It's hard to think of an example where like the technology itself moved as quickly. I mean, and others should feel free to weigh in too. But this does feel like, I think, uniquely challenging. But part of the reason I brought up the telemedicine example is like that actually is, to my mind, an example of like where the technology was ready before the people and the processes. And I think that went quite well. At the point that we needed it, we were able to move quickly and implement it. It's a much more simple technology. So I mean, I think that's why it doesn't feel exactly like a fair comparison. But I think if we are at that moment of needing to move quickly, I do think that like that was an example of we were able to get the people and processes in place pretty quickly to use a technology that fundamentally was ready.
Julia, I just want to answer the question.
Yeah.
There is an example. In radiation oncology, we have been using algorithms for a long time, since 1959. And there is a clinical profession that is in charge of supervising the algorithms when they calculate the radiation. And until 2001, that was not regulated. But because of many accidents that happened and articles in the New York Times, then a residency was created, and you have to have training. And so it's actually very parallel to what is happening with AI today.
Great. So radiation oncology. North Star.
Yeah, this was a great talk. I really like your insight about so much of the job to be done is really about building capacity through people, processes. Now, I know you've got an incredible body of work, researching EMRs. And I guess my question for you is like, hey, how do you think, AI is going to change the EMR itself? I mean, looking at recent announcements around Oracle building an AI-native EMR, what does that even mean, for example? All the way to Epic saying that they're going to launch 100 features that are AI-enabled. And we already know so much of even and beyond tools today is changing how notes are captured. And clearly the EMR as an interface, as a lot of data capture, is going to play a hugely important role in part of capacity.
Yeah, another great question. So my sense is that like a lot of the first wave AI tools are fixing a lot of the things that we did wrong with electronic medical records to begin with. And I think, again, we made them very like user-friendly, complex documentation tools that didn't do a lot of things, especially around like facilitating communication and coordination of care. And so I think those problems are felt very acutely, and so some of the tools that we're seeing are the ones that are addressing those problems. I mean, ultimately, I think we will think about the electronic medical record as just like, it's just the thing you log into to start whatever it is you're doing, and then like the rest won't really matter, because all we're going to be doing is optimizing sort of processes and how information is displayed and presented. I don't think we're going to think about like, oh, that was the AI in the EMR and that wasn't. Like it will just be a totally blurred distinction, and information will just be presented, and I hope like a more intuitive way, in a way that makes it easier to understand like what's happening with a given patient or patient population, what to do next. So what I hope is like it will just feel like well-designed software, which is what it has not felt like for a really long time. And that's where I think it will be AI in the background. But like ultimately, I think we all hope that, again, this is partly why I brought up the EHR vendor market power piece of this, because I think like the real potential is when we can create a much more open ecosystem. And I do worry right now that like there will be some constraints on the extent to which we can really get to that like ideal future state if so much does have to go through whatever that local electronic health record vendor is. So in the near term, I think it will be around optimizing that, but I hope in the not too much longer run, like you won't even think about your EHR as sort of like, oh, it's Epic that's doing this, or it's Cerner or whoever.
It's a great answer, thank you.
Ron?
Sorry, was there another question over there? I guess I'll go ahead and go. Thank you so much, Julie. Always a pleasure to hear you speak. I'm really interested in your framing of the AI unit in terms of kind of like the effector arm, if you will. And I think the diagram shows what seems like a complex adaptive system where you kind of deploy AI and then it becomes less linear, if you will. Yeah. And I'm curious, if you think about designing this AI unit, do you think if you maybe move away from the AI space a bit and we're just thinking about building a clinical program or building a clinic or building like a care model, I mean, in many ways, those are units as well. And then if you deploy AI in it, how do you think about evaluation? Like, do you evaluate the entire program? Do you evaluate the AI itself? Do you evaluate the software? Do you have any thoughts about that?
Yeah, God, these are great questions. I mean, I think it sort of depends on what the goal is of what you're trying to understand. I mean, ultimately, I think you probably set up that clinic to achieve a set of outcomes, whether it's better access or better. So, I mean, I think the first piece of it is really understanding, does the system as a whole achieve the outcomes that you want? But I think then if the answer is no, you'll have to then go back and figure out why. Like, what piece of it is not working? Is it the actual foundational AI that's not doing its job? Or is it how the people who are interacting with that AI, are they not doing their job? So I think in the piecing apart of understanding that bigger picture relationship, like, you will ultimately get into trying to understand the different components of, I mean, it always comes back to, right, people, process, technology. And so I think we'll need to have a way of understanding each of those pieces and how they interact. But again, I think it is hard to do as the lines get blurrier and blurrier. Again, especially as some of the things that we think of as what people do is really a human-AI combination. And so I think that work will get harder as these sort of units get bigger and it's a lot blurrier.
In some ways, it reminds me of the internet or cloud computing, where at this point we don't evaluate the impact of cloud computing on a business. You evaluate the performance of the business, but it's impossible. The business is impossible to operate without the cloud, and I wonder if AI is moving towards that direction.
Yeah. I mean, even just to talk about AI is like, it's such a big, it's just a foundational set of capabilities and can be applied in so many different ways. And so I do think that's where it is helpful to think about the application layer, like what problem are we trying to solve with this particular tool or solution? That simplifies it a lot as we're trying to think about these relationships between cause and effect. But I agree, like if we said like, what is the value of AI at UCSF Health? Like, I don't even know how I could really answer that question. That's where we need Eric Brynjolfsson. Okay, thank you so much. Look forward to the rest of the day.